Hello, I'm Junho Jung from the Medical History in Modern Korea. Along with rapid economic growth since the 1970s, people's aspirations for a better society have also increased. And medicine was no exception. The civil movement and the transition to a democratic system in 1987 brought many changes to medicine as well. Along with the rising demand for healthcare, civil society demands for how medicine should work and be distributed as a public welfare also increased.
Making of national health insurance.
According to the National Health Survey conducted in 1962, which led to the enactment of the Health Insurance Act, the per capita national income of Koreans was only $94.4, and the per capita medical expenditure was 66 won per month, which was far from enough to implement health insurance. This meant that even if a health insurance system was introduced, few people could afford to pay premiums regularly. It was also difficult to start a health insurance scheme if one does not have financial resources. There were some attempts to limit coverage to each workplaces that could afford it, but few businesses were large enough to do so in Korea's economy during this period. At its core, the concern was that health insurance would add burdens to the business and the government, and thus it would hinder the potential for economic growth, which was a key issue for Park's regime at the time. The idea was that forcing individuals or companies to pay for health insurance would lower their real incomes and thus affect economic growth. In response, the Health Insurance Act of 1963 removed the compulsory coverage provision. This meant that individuals and companies were encouraged to purchase insurance only if they feel they need it. At that time, no one at their income level was willing to purchase insurance on a non-compulsory basis. And instead of creating a national fund, the law was designed to be a combination of local and company associations, which would raise funds from each other. As a result, although the law was enacted, it was not well received. In 1963, the Health Insurance Act was enacted, but it was not until the early 1970s that an enforcement decree was enacted to support practical implementation. As of 1971, it was estimated that even a limited health insurance program for large employers would require about 10 billion won in funding, and the government was not prepared to provide it. Furthermore, the medical profession was also reluctant to participate in health insurance, as the opinions of those actually providing service, the medical professions were not reflected in the law. By the mid-1970s, however, this social context has changed dramatically due to political and economic changes. First, there was the October Restoration in 1972, and this resulted in a strengthening of the autocratic system, which concentrated all power in the hands of the president. This was followed by a significant strengthening of the bureaucratic authoritarian system, which allowed for the coercive suppression of dissent from all sectors of society against government policy. In addition, By the time the third five-year plan for economic development was finalized in 1976, per capita national income became 8 times higher than it had been in the early 1960s. Between 1970 and 1974, total national health expenditure grew at an average annual rate of 31.2%, and per capita health expenditure grew at an average annual rate of 28.8%. During the same period, the national income growth rate was 24.6%. What these statistics indicated was that health expenditure grew faster than income growth, meaning that as incomes rose and living standards improved, people became more interested in medical care and health. As the public's demand for healthcare increased, the actual establishment and implementation of a health insurance system became a task that could not be ignored by the Park regime. Economic growth provided a backdrop to make this possible, and social discontent with the strengthening of the dictatorship provided the motivation to implement a full-fledged health insurance system.
Implementing national health insurance.
With the aftermath of the global oil shock in the first half of the 1970s, the government was cautious about implementing a health insurance system that required a large financial investment. As the implementation of nationwide health insurance required the participation of a large number of companies and individuals, as well as the injection of huge government resources, opinions were divided even within the Ministry of Health, which was in charge of the comprehensive revision of the Health Insurance Act and implementation measures. In a way, there were those who argued for a limited association schemes and gradual expansion, and on the other hand, there were those who argue for the full introduction of integrated nationwide health insurance. However, under the dictatorship, where the voice of civil society was not heard, the people, the actual beneficiaries of health insurance, were largely excluded from the policymaking process. The only non-state organization given a seat at the table to negotiate details of the fee-for-service system was the Korean Medical Association, an organization of doctors who would be the actual implementer of the health insurance. In the end, the 1977 revision of the Health Insurance Act combined compulsory and voluntary enrollment, but did so in a phased manner. The first to be targeted were companies with 500 or more employees that were assumed to have sufficient financial resources. Another important aspect was that each health insurance association was to operate on an independent basis. This was positive in that it eliminated the administrative difficulty of having the government manage all of the finances for health insurance. But it also made many of them unviable, because there was a huge difference in the amount of money that a large employer with ample financial resources could raise versus the rural and urban poor. The nature of insurance is that the more members a scheme has and the more capital it has, the more secure it is and the more financially stable it is. Moreover, paradoxically, the more members who can pay, the lower the individual premium that any one person has to pay. Conversely, rural areas were already losing population due to rapid urbanization by the late 1970s. And the income gap with urban area was becoming increasingly severe. With fewer enrollees and fewer people who were able to pay sufficient premiums, rural enrollees have to pay more than their urban counterparts to secure adequate coverage, ultimately defeating the purpose of a social security system in the sense of guaranteeing the basic right of the economically disadvantaged. Despite these various constraints, introduction of the health insurance system has led to improvement in overall healthcare utilization and accessibility. For example, in 1977, before the implementation of rural health insurance, a survey of local residents' healthcare utilization in Suncheon, located in southern end of Korea, showed that 23.2% of people had not received any medical treatment even when they were sick. 52.2% of people had not visited a hospital in the past year, especially due to economic reasons. 35% of respondents said that they had not sought care because they could not afford it. And women were more likely than men to use pharmacies instead of hospital due to cost. Regional and gender disparities in access to healthcare were emerging. However, after the introduction of rural health insurance in the late 1980s, albeit at the limited level, women's outpatient use, which has been low, increased significantly more than men's. Outpatients and inpatient use by the elderly also increased, and the number of visits to institutions and days of treatment increased. For groups with previously low access to healthcare. However, at the same time, the steepest increase in the number of visits and the days of care was among the highest income groups in the region, indicating that despite the introduction of the health insurance system, the limited financial resources of rural unions resulted in high out-of-pocket expenditures and limited access to health care for the economically disadvantaged.
Integration of health insurance.
The 1977 Health Insurance Act still did not provide universal health coverage due to the high number of non-enrolled people and the lack of pooling of funds. Although coverage was extended to establishments with 16 or more employees in 1983, with plans for gradual expansion, only 39% of employees were covered. On the other hand, despite the introduction of the medical insurance system, the actual cost of medical care paid by individuals at hospitals was still high. Since there was insufficient government support to finance medical insurance, coverage for many medical services was insufficient, depending on the financial situation of each association. For this reason, high-cost medical services were not covered by medical insurance during this period. In 1980, out-of-pocket medical expenses amounted to 84% of total national health expenditure. And this meant that only 16% was covered by insurance. Simultaneously, the growth of healthcare after liberation was left to the private sector. So costs were determined by the market. At the time, 2/3 of all beds were provided by private healthcare institutions. For insured patients, healthcare organizations were reimbursed by the state-determined fee-for-service system. But due to the fragile finance of the healthcare system, these rates were set very low. Medical institutions were only able to receive about 60% of the cost of treating insured patients. Doctors protested that insured patients were to their losses. There were instances of hospitals refusing to accept insured patients because they were overwhelmed with patients, or forcing insured patients to pay out of pocket for their visits, while insisting that they could not claim benefits due to stringent screening. This was more of a problem in rural area than in urban area. An increasingly aging rural society and frequent injuries from various manual labor created a greater demand for healthcare in rural area. Yet, the ability to pay and the number of members were lower than in urban area, resulting in chronic deficits. Local associations in rural area chose to raise premium to improve their deficits. And as a result, rural residents had to pay higher premiums than those in urban area in spite of lower incomes. A backlash began to emerge against the excessive premiums paid in rural area. In addition, criticism emerged that the national health insurance system was not adequately redistributing wealth, an important role of the social security. As a result, public demands emerged for a complete overhaul of health insurance system, compulsory application of health insurance, and integration of urban and rural health insurance financing, with a focus on rural area. This was also a reflection of the political changes at the time. Korean people had won a presidential electoral system and ended military dictatorship following the 1987 movement for democracy. This experience of democratization led to the growth of civil society and social movements in Korea. The movement for the unification of healthcare insurance was joined by other civil society movements in 1988, leading to widespread protests from agricultural sector. In June 1988, rural associations across the country formed the National Health Insurance Task Force. Their demands were for the integrated management and operation of associations and financial resources, as is the case today, and for premiums based on income rather than on associations. The National Health Insurance Act passed the National Assembly unanimously in March 1989. But a sudden veto by the then president crumbled the legislation. It would be another decade before the country finally realized the universal health coverage for the entire population. In 1994, labor, farmers, citizens, healthcare workers, and others formed a huge coalition to demand the unification of health insurance, expanded coverage, and equitable insurance premiums. However, the movement slowed down for a while when Korea's severe economic crisis hit in 1997. However, when President Kim Dae-jung took office in 1998, he listed national health insurance unification as one of his top 100 national priorities. After the 1997 economic crisis, the number of socially vulnerable people increased, and expanding national welfare became an important issue. Among the political and economic changes, a comprehensive reorganization of health insurance received considerable support. On December 31, 1998, the National Health Insurance Act was promulgated, integrating the health insurance of associations, public servants, and teachers in each region. The National Health Insurance Service was established to manage the nationwide financial integration. In 2000, the National Health Insurance Service and individual workplace health insurance was merged to form an integrated health insurance system. And then in 2003, the financial integration of rural, regional, and workplace health insurance was completed. The process of the introduction, growth, and integration of the Korean health insurance system shows how the needs and demands of each stakeholder changed in line with the political and economical change in Korea after liberation. It also illustrates how the growth of the healthcare system was closely linked to the political growth of the society. In post-liberation Korea, the most pressing issue were relief and the management of acute infectious diseases. However, as society stabilized in the 1960s, the overall demand for healthcare increased. At the same time, a health insurance system was established, although symbolically as one of the means to combat political instability. With rapid economic growth in the late 1970s, the demand for healthcare increased, and the growth of civil society organization in the wake of the democratic movement served as a channel for people's voices to be heard in the fight for universal welfare and the right to health. However, under the repressive political system, elements that could have hindered economic development were suppressed. And it was not until the late 1990s, when full institutional democracy was achieved, that a universal and integrated health insurance system that included rural and poor population became operational.